Welcome back, everyone, to the second episode of Open Globe Talk. At the studio, we are joined by Dr. Lloyd Williams, who is the director of two divisions, the Global Ophthalmology Unit and the Refractive Surgery Department at the Duke Eye Center. He is also the 2024 president-elect of the North Carolina Society of Eye Physicians and Surgeons. Dr. Williams obtained both his MD and PhD in neuroscience from Tufts University School of Medicine, and then completed his ophthalmology residency at the University of Utah before finishing a cornea and refractive surgery fellowship at the Filmer Eye Institute. He has been recognized multiple times for his humanitarian work and is known to be a dedicated global ophthalmologist. And so we are excited to have him start our conversation today, and I can't wait to ask him questions.
Thank you. Good to be with you this morning.
So, Dr. Williams, I think your work is pretty non-traditional in the sense that you do have 2 months out that you put forth in traveling outside and giving your services for free and teaching trainees in underserved communities to become ophthalmologists and serve their communities. So when did you realize that you wanted to be an ophthalmologist, and what prompted you to the field?
The moment for me, I'll go back. My parents were missionaries in Papua New Guinea when I was a little kid. And so I spent some of my early childhood there. And so I always had a sense that that's what I wanted to do in medicine. So after my first year of medical school, I took that summer and went to Zambia and worked in a hospital called Macha Mission Hospital. And basically I did general surgery while I was there. And I started working with burned children and kept doing that over the next sort of 7-8 years of my MD PhD. So while I was in my third year of medical school, I was working in the hospital in Zambia doing general surgery, and a guy came from Ghana and did cataract surgery on about 25 people, all of whom were completely blind. And my job as the medical student was to take their bandages off the next day and see if they could see. And they all could. And I thought, well, this is really the most amazing thing I've ever seen. It's like doing miracles. And the first lady, I remember I'm leaning over her and I'm not super tall, but I'm pretty tall. And this is sort of little older African woman, and I'm leaning over her and I'm saying, "What can you see?" And she says, "Makua," which means white people. And the whole ward got a good laugh out of that. But that was the moment that I thought, I think this is what I'd really like to do. And it kind of fit with the engineering background that I have. As you know, a lot of ophthalmology is pretty technical. We use a lot of tools that involve imaging or other engineering type applications. And also everything's really small. And it turns out I have pretty good hands for microsurgery. So it just kind of made sense.
Wow. And so interestingly, you helped found a nonprofit organization called Help Mercy International.
Yep.
And it kind of comes back to, your roots and how your parents inspired you and other people who came into your life inspired you. Firstly, what is Help Mercy for our audience who don't know what it is, and why did you get started with doing it?
So Help Mercy actually was the name of my first patient ever as a physician. So when I was a first year med student and I arrived at Macha Mission Hospital, I'm in the Land Rover. I've just been sort of shaken to pieces, driving 5 hours on a 30-mile long road, bouncing all over the place. And a guy runs by and he says, "Do you know how to take a blood pressure?" I said, "Sure." He said, "All right, you're anesthesia. We're going to the OR." And I was like, "I'm anesthesia? Like, how am I anesthesia? I haven't even..." But I had done some EMT stuff and was trained as an EMT. So I went and I did anesthesia for a case of a 6-year-old girl who had fallen into a fire while having a seizure. And she had burned her hands so that from about this knuckle down, it was just literally just charred pieces of bone sticking out. They're like broken off. It was really pretty horrifying. And I spent the next 2 months, among my other duties, changing her bandages every day, mostly without anesthesia, because if you gave her anesthesia, then she couldn't eat. If she can't eat, then she doesn't have enough protein to heal. And so, just trying to be delicate enough that I didn't cause her too much pain. And we did skin grafts. And when I got back to Boston for second year med school, um, the nurses and doctors sent me a message. They said, "We know you really cared about Mercy a lot. She's recovered, but her hands now, if I could bend my wrist so that my fingers touched back here, the skin grafts had contracted." They said, she needs reconstructive surgery if she's ever going to be able to use what's left of her hands. So Help Mercy was born out of me trying to get her reconstructive surgery. So at the time, I had met Matt Damon's brother in Boston, and we'd become friends. And I was a cyclist, and so we rode together and stuff. And I said, well, I was thinking about doing a ride to raise money for this girl. And he said, well, you should ride down to my brother's house in New York City. So basically, Help Mercy was born out of me getting on my bike and riding from Boston to Matt Damon's house in New York City and back, to raise money for this little girl to get reconstructive surgery. And we were able to reconstruct her hands. And so she ended up basically with hands like this, but with a thumb and some, sort of short fingers. You can actually do quite a lot. So we helped her go back to school, and she was able to write and dress herself and feed herself and really have a pretty independent life for about a decade. Sadly, she did die in a seizure about age 17. But I think her life was a lot better for those 10 years for what we were able to do for her.
Yeah, and that's actually a pretty unique story. I don't think I would have expected how that story gained its momentum and how it influenced your life and how it ended up finding an organization that now helps a lot of children going forward. So moving on to our main topic of corneal transplants, which is something that you take pride in. You also have a lot of expertise in. You were the first person to perform corneal transplantation in Sierra Leone, which, for those who don't know, it's a very difficult country to go to. There's a lot of safety issues that are always sent, from the U.S. Embassy that please don't travel here. But yet you were able to go there and also, establish this corneal transplant tradition. So what was it like to build an infrastructure for that to even take place?
Yeah, it's, cataract surgery, as we all know, pretty much is you do the cataract surgery, you see the post-op, and then it's done. And there's really not much else that you have to do going forward. Maybe they get some PCO and need a YAG in the future, but even if they do get some PCO, usually it's not back to blind, it's just reduced vision. So cataract surgery obviously has been the sort of the low-hanging fruit in international ophthalmology. So with cornea transplant, the first thing that you have to do is you have to really develop a relationship with local people, or you have to move there and live there, which Duke isn't supporting me doing yet. So we took the other option. Dr. Jalika Mustafa was an amazing resident at the Kenya program that Jeff Tabin had known about and had talked with her mentors. And so he introduced us back in about 2016. And so I had gotten to know her over the course of about 4 or 5 years and had done some cataract surgery there. And out of that, she and I began talking about some of the patients that they had who really needed cornea transplants, and is there something we could do? And so she invited me to come and do transplants. And we, as a as a trial run, got 8 corneas in July of 2021 when Duke finally let me start traveling again after COVID. And we did 8 transplants together. I did the first 3 and then taught her, and she began doing them. So Dr. Mustafa then ultimately became the first person from her own country to do, I think, any organ transplant in the country, because to my knowledge, they don't have a kidney transplant program. I could be wrong, but as far as we know, and it really generated a lot of excitement in Sierra Leone. In fact, we ended up at the end of that week on the TV show Good Morning Sierra Leone, which I thought was pretty cool. And both of us talking about, what it was like to do the first transplant. But then, doing the transplant is kind of the easy part. In the long term, the postoperative care was done by her, and the other ophthalmologist, or the other main ophthalmologist in Sierra Leone, whose name happens to be Lloyd Harrison Williams, where mine is Lloyd Berthold Williams. So it's a source of ongoing and tremendous confusion that we both have the same name. But he does a lot of the postoperative care. So a lot of that week was doing the surgeries, figuring out how to, just have the supplies, helping the staff understand how to scrub for the surgery and all of that. But it was also teaching Dr. Mustafa and the other Dr. Williams about who's a good candidate, who's not a good candidate, and how to do the postoperative care, which of course then we stay in touch via WhatsApp if there's any questions about what should I do with this person, send pictures and sort of do telemedicine. But it was super exciting. Our first patient went blind at age 14, and we met her at age 43. She was NLP in her right eye, LP in her left eye, and we did her transplant, and she ended up 2100 post-op day 1 and saw her children and her husband for the first time. It was pretty exciting. I mean, that was one of the most special moments I've ever had in ophthalmology.
Wow, that's pretty significant, going from not being able to see anything, or just seeing the light on and off, to actually seeing the people that, you've been longing to see. And, probably at the age of 14, she may have gotten married, but she probably didn't get to see her children.
Yep.
So that's a really difficult thing. Um, where do you get the transplants from? Because I've seen those photos with you holding the cooler boxes, but I've always wondered, are you carrying them from the United States, or are
Yep.
they coming from local?
So there are no eye banks in Sierra Leone. I've done transplants in Indonesia and some other places as well. In Indonesia, there is an eye bank, but it's not producing a lot of tissue right now. So even for there, we usually bring transplants from the United States. The United States actually produces isn't the right word. I guess collects would be the right word. Enough tissue that there is excess tissue that can be used for research and can also be used for international missions. And so the 2 organizations that we've gotten tissue from so far are Miracles in Sight, which is based in North Carolina, and Cornea Gen, which is sort of a national, actually an international eye banking company.
Very cool. Um, and I guess, are there any challenges when you carry those transplants with you on the plane? Because I think in a previous episode we had one candidate who did something similar, and I think it was very difficult for him initially to bring those items over.
Yeah, it's tricky because, I've carried tissue now to Sierra Leone 5 times, I think, and also to El Salvador and Indonesia. And it's a little bit different every time. A lot of it depends on just who you run into at the airport. And so sometimes it's no trouble, sometimes it's a ton of trouble. Um, I'd say, for somebody who's interested in doing it, the first thing is to talk to Miracles Insight or CorneaGen or wherever you're getting it from, and make sure that you have all of your documentation for the tissue intact. Then it's also super important to have letters from the host country so that when you're arriving at the host country, they know the Minister of Health or the head of the eye program for that country has invited you. They know you're bringing the tissue. They've asked you to bring the tissue. All of that's really important and often smooths things out when you're going through customs. The other tricky part, though, is just getting through the security at the airport. And I can't say that it's been consistent. I've gone from like Raleigh Durham. I think they know me now, and they're like, "Oh, it's that guy who brings the eyeballs." And so it's been really smooth at Raleigh Durham for the last couple of years. But last time I went through New York, they basically made me open up the box, take out all of the things of eye tissue, swab the box for bomb residue, run the box through the scanner, which I try to avoid. And most of the time they'll let you not scan the eyes, but it doesn't seem to kill the tissue. So, if they ask me, I say, we don't want to scan it, we don't want to open it. If they push me and they say, well, you're not going through unless you scan it or open it, then I'll scan it or open it, kind of whatever has to happen.
Yeah, yeah, that's pretty difficult times, unfortunately. And there's not a lot of transplants that can be delivered straight to a distant area. Um,
Yep.
what are the benefits of a corneal transplant center being built in a country? I know you touched upon, changing the lives of somebody who wasn't able to see and now is able to see. But are there any impacts for neighboring countries as well? Because I know that Sierra Leone definitely does depend on its neighboring countries for um, resources as well.
Sure. It's something I've thought about a lot, and it's something Dr. Mustafa and I also discussed quite a bit. If you think, given the value of a cornea and the time and effort that goes into a transplant and all the postoperative care, you might say, well, why not just take that time and effort and put it into 100 cataract surgeries instead of one cornea transplant? And I think it's a legitimate question in the sense that in some countries, like say South Sudan, where I also travel, um, yeah, I don't think there's enough infrastructure to really do transplants yet, and you'd have to find just the right patient. And would it really make sense from a financial standpoint to spend the time and energy on a transplant when you could have spent that time and energy on, say, trachoma surgery or cataract surgery or even glaucoma surgery? Um, but the other side of it that has been interesting and was a little bit unexpected is that out of doing the cornea transplantation in Sierra Leone, it really raised the profile of the entire eye division. And so the benefits to the 52 patients that we've now done transplants on are a lot of them can see now and they couldn't, which is great. But the other side of it is that Dr. Mustafa actually was promoted to Deputy Minister of Health. The president of Sierra Leone is actually tweeting about eye care in his country and about the contributions that Dr. Mustafa has made. And they've offered to provide land for us to build a new tertiary care center that would, I mean, currently the National Eye Center at Connaught Hospital has 2 operating microscopes and 2 slit lamps for eye exams. So, only 2 doctors can work at a time. It's we're hoping to have a center where all of the new training doctors could work and have 10 lanes and 5 ORs and really be able to put a ton of manpower into into taking care of patients, because right now with the size of the facility, there's only so many people you can run through that in a day, compared to the amount of blindness in the country. So the really exciting thing is it's, as a country, they really took a lot of pride in, hey, we're here in West Africa and we're doing organ transplants, and we're changing the lives of people in our country with advanced medicine, and it really raised the profile of the whole eye surgery program, and has brought attention and effort into something that for a long time sort of was languishing on the side. And it's also really helped Dr. Mustafa in her career. And she's going to be such an important leader in eye care in Africa. It's so exciting to watch her grow. And I can't wait to see what she's going to do in the next decade. But what she's already doing is amazing. I mean, she just rolled out the malaria vaccination program for children in Sierra Leone, and she's an eye surgeon. It's really awesome. And a lot of that has come out of this program that she and I developed together.
That is super cool. And I did get the chance to see Dr. Mustafa come to Duke, only due to Dr. Williams. And it was a really fantastic session to see somebody coming from West Africa, changing the face of their country and sharing what their thoughts are. There's a lot of misconception about countries like Sierra Leone, and you speak so lovingly about the people there and how prideful they are of their nation. I, and we also designate countries like Sierra Leone as underdeveloped, but there's a lot of support that comes from top leadership. And I wondered, how is Sierra Leone when you go there? And, what are the people like?
Yeah. A lot of times we're spending our time in Freetown, which is really it's quite an impressive city. I feel like it's like an African version of Hong Kong, because it's sort of smashed between the mountains and the ocean, and so it's super densely populated, and there's just people and noise and movement everywhere. It's almost overwhelming when you come from sort of suburban Chapel Hill and get plopped down in Freetown. There's so many people. It's really quite incredible. And it's a country of very young people. I'm always struck as we're driving through the city and stuff, just how young and fit and beautiful everyone is. Like it really makes you like, I always want to come back and like go to the gym and stop eating bad food. And I'm like, oh, I'm fat. Look at these people. They're amazing. So there certainly is poverty. And as you go out into the rural areas in the countryside, that becomes quite a bit more pronounced. And there certainly is some lack of healthcare in some areas. For example, usually when I'm there, we'll see maybe one or two patients who come in who have like a big orbital tumor or a big sinus tumor that's pushing their eye out. And there really quite isn't the capacity to handle cases that difficult. But at the same time, the people of Sierra Leone, I wouldn't want someone to underestimate the strength of the people and their character and their drive to succeed in the way that they're able to put things together with the resources that they have. And I'm convinced that Sierra Leone is going to grow and grow and grow, as long as there's not, say, another civil war or something like that. So it's really an exciting place to be, and in a lot of ways it's kind of humbling, because it's easy to sit sort of in your little suburban place and think, oh, I'm going to go help those people over there. I don't feel that way anymore. I think I had a wrong idea when I first went to Africa that I was going to help people. And it sort of, I was disabused of that pretty quickly. Not that I don't help people, but that the way I like to think of it now is I work with people and I create partnerships or a lot of times they create a partnership with me, but um, I go places where I'm invited. I teach what I know. I learn what I can. And I really think of people like the other Lloyd Williams and Dr. Mustafa as just straight up colleagues, the same way I think of Terry Kim and Leon Herndon and Missy Dalavoy. They're super amazing people. They know some things better than I do. I know some things better than they do, and we just learn from each other all the time. And I think when you approach it like that, it's a lot better way than, oh, I'm just going to go help these poor people. That's definitely not the right way to approach things.
Speaking of partnerships, you have started a Duke Global Ophthalmology Fellowship,
Yep.
and this was perhaps the reason why you came from Utah to Duke in 2019. Um, what have been certain challenges associated with the fellowship? And I know COVID is one of them, but barring COVID, what about just thinking about a normal time and you're setting up a fellowship? What are some of the challenges that come with it?
Obviously one is financial. Fellows want to get paid. And then also to do a global fellowship, in addition to sort of covering the fellow's salary and their work at Duke, you also have to cover their travel and sort of their living out in wherever you send them. So we calculate that maybe about $125,000 is necessary for a year for a global fellow, which is a bit more than for one of the regular fellows. And Miracles in Sight has generously offered to fund that for 3 years. Miracles in Sight also helps fund the regular cornea fellows at Duke. So it was sort of a natural partnership. Um, the cornea fellows right now at Duke, for the first time this year, each of the cornea fellows did an overseas week with me. Dr. Sklar went to Sierra Leone. Dr. Garson went to Honduras for a week, and Dr. Tien went to El Salvador with me, where we did 19 transplants in a day, which was a pretty exciting day. And then he also went to Nepal to work with Bidya Pant, learning M6. So I think that was a pretty exciting experience for Dr. Tien. So moving forward, all of our cornea fellows will have a chance to spend a week overseas with me. But the cornea fellow themselves is going to probably spend 4 to 5 months overseas and do a global health project and really be trained in cornea both here and there. And I think one of the things that's exciting about that is it's going to be a unique fellowship in that most of the global fellowships right now in the United States have you finish and you've got a specialty in global ophthalmology, but I'm not really sure what that is when you apply for a job. Say you finish that and then you apply to a job at the University of Utah, let's say. What does that mean that you can do in the OR that you wouldn't be able to do as a comprehensive ophthalmologist? And how do you sit down with the people who do the credentialing and say, well, this is what I can do and this is what I can do and I should be allowed to do this in this OR. And they say, well, we don't really do trachoma surgery here anyway, so it's irrelevant, right? So this fellowship, we've talked to the AUPO and they count cornea transplants done overseas as well as cornea transplants done here, as long as I'm the one who's doing the teaching. So the person who comes for the global cornea fellowship will actually leave as a cornea trained fellow, and then can go out into practice and say, I'm a cornea fellow who has a specialty in global medicine, but I've trained to do DSEC, DMEC, PK, and I would expect they'll get well over 100 transplants in the year, because most of the time when we go to Indonesia or Sierra Leone, we'll do at least 20. And so they'd probably get 4 trips like that minimum, and then all of the follow-up and everything else. But that'd be 80 transplants right there, plus all the ones that we would do here. So I think it's going to be a really exciting fellowship. I'm hoping we get some really great applicants.
Yeah, that actually sounds really cool. So you have a designated position for the global fellowship, but they're technically cornea trained individuals so that they
Correct.
can utilize that skill set for their job or employment in the US. Um, in regards to the number of transplants or procedures you do abroad, what are the factors that determine how many a fellow is able to do? Because I'm sure teaching somebody alongside can be very difficult, but the fact that you're able to accomplish those numbers is very impressive.
Yeah, it's, and when you do fellow, like for Dr. Sklar, she had done her or is finishing her fellowship in a couple of weeks. We were in Sierra Leone about a month ago. When you've done transplants in America, you get pretty good at doing, say, a PK and suturing. And then you go to Sierra Leone and you think, wow, this is really hard because my patient is blocked, but otherwise totally awake. Uh, they, the pathology is usually worse. So, for example, a lot of the transplants there are people who have prior perfed ulcers that perfed like maybe 5 years ago, and the iris is stuck into the perforation, and so now you take the cornea off, and the iris is all chewed up, and it's sticking to the cornea, and you're trying to remove that, and the patient's awake and squirming around, and sometimes their eye is even moving a little bit because the block doesn't have wide ACE in it. And so Dr. Sklar learned how to do transplants at Duke and then learned how to do like hard transplants in Sierra Leone. And so I think that was a really great experience for her to see, to learn how to do an even higher level of transplant, so to speak. And that'll be part of the global fellow learning to do cornea. So I think even though they're going to be doing some things other than cornea, I think when it's all said and done, the level of cornea experience they're going to have is going to be really high because the level of difficulty of the cases overseas, just like cataract surgery, the level of difficulty in the transplants is also quite high. And so you really have to find your A game and bring it every day when you're there.
And interestingly, as we're talking about the types of procedures that fellows will or a fellow will be experiencing per year, I will. I wondered, are they going to get experience in glaucoma or other types of procedures, or will it mainly be in cornea?
One procedure the three procedures that definitely the fellow is going to learn would be trachoma surgery on the eyelid, M6, and cornea transplant in the developing world. Most of that is penetrating keratoplasty. Although DSEC for bullous keratopathy, there is a substantial amount of bullous keratopathy due to bad cataract surgery. And sometimes you're catching that early enough that patients don't need a full PK. So those are the three that are sort of the bread and butter of what I do in the developing world. But glaucoma is an important procedure, and as people are learning, for example, how to apply MIGS to developing world situations, and when it's appropriate or when it isn't, I'm hoping that will be also included because I think there's for a surgeon who's not planning on living there and not going to be able to do sort of consistent follow-up over the long term, I'm not sure that things like Ahmed valves are a great idea. In fact, I'm pretty sure they're not a great idea. There's a lot that go wrong in the short term, but things like MIGS, Cahook dual blade, Omni, stuff like that, where you're not necessarily leaving hardware in the eye, I think have a real opportunity to lower pressure, or delay glaucoma, and improve outcomes in patients for whom drops may not be an option.
Yeah.
So that's something I'd really like people to learn. Leon Herndon is involved with our global program, so I'm hoping that he'll help us with teaching in that area. And I think if somebody would like to learn strabismus surgery that would also be an area that we could apply some effort, since Grace Percala-Picorn is also involved in the global.
So is it just three faculty that are manning kind of different areas of ophthalmology during this period of training for the fellow?
Most of it will be through me, but we want to look at each fellow individually and talk with them. Okay, what are you interested in? It's not going to be something where it's like this is what's going to happen 100%. This is what you have to do. Obviously, there are going to be sort of baseline requirements, but if somebody has a connection already to an area, let's say we took a fellow who was born and grew up in Indonesia. Well, then, let's spend more time in Indonesia doing transplants there, and working with our contacts there. Or let's say it's a fellow who's, for example, I was with Grant Justin, who you may remember as the retina fellow a couple of years ago, and he's working on setting up retina equipment and a retina program in Sierra Leone. And so he and I were there together, and he brought his resident with him. Well, his resident has found out that he's 40% Sierra Leonean. And so, if he were to do the fellowship, it makes a ton of sense for him to go to Sierra Leone and spend time spend time in a country that he already has a connection to. And I think helping people establish connections that are natural helps make those connections long term. And obviously, that's the thing that's really going to change that's the thing that's going to really change curing blindness in the world, is people going to places over and over and over again, the natural connections that they have, teaching, developing strong relationships in that area, learning in that area, and really building programs with the local people, being invited to teach the things that they know and so on in specific areas over and over and over again. And some of the great examples of that are Jeff Tabin's connection to Nepal, how that grew into the amazing eye care that takes place in Nepal right now. And obviously there are other great examples of that.
Yeah. And you mentioned minimums for doing the fellowship, like minimum number of procedures. How do you determine that number?
So the AUPO sets a basic standard for cornea fellowship. I don't have the numbers offhand, but if I'm not mistaken, it's 70 transplants and roughly 2,000 clinic visits in a year. And the 70 transplants, of those, roughly 15 have to be PK, 15 DMEC, and 15 DSEC, so that you have some understanding of all of the different types of procedures that take place in cornea transplantation.
So you're actually borrowing from the actual like cornea or specialty fellowships and then putting them as part of the Go fellowship, so that there is this standardization for fellows.
That's correct.
That
and so technically what Duke is doing is adding a fourth cornea fellow that will meet all of the cornea fellowship requirements as per the AUPO, but that fourth cornea fellow will spend more time with me and a lot more time overseas than the other fellows.
That makes a lot more sense. Dr. Williams, I think I've picked your brain a lot about the coming up fellowship. I know there's a lot of work that's gone in. A lot of people have put in many hours trying to establish this fellowship. And I know it's been a dream of yours since, well before 2019, but, it's a going progress. And I'm very impressed that your team has been able to stay committed to that goal. My last question is, you mentioned your hobbies, and sometimes we often forget that there's a life outside of the difficult things that we do in our workplace. And so what importance do hobbies hold for you in your life? You've been a competitive cyclist, you build guitars, they've been featured in Mercy International, and I think that's kind of very inspiring to see that you have so many other your life outside of medicine is as colorful as life within medicine.
Um, I think you know if you take personality tests and stuff, I think maybe the expectation is that a lot of doctors are sort of type A, um, analytical, and so on. When I take a personality test, a lot of times it puts me as artist or something like that, and I think, well, that's weird, as somebody who was an engineer and everything. But I do think looking at some of my mentors like Jeff Tabin and Alan Crandall and stuff, the people who are doing really amazing things in global ophthalmology, I think tend to be more creative people who are comfortable doing things that aren't safe, who are comfortable walking a path that is not well worn. Because a lot of times I don't know what the right next step is. So we sit down and we say, okay, let's build an eye center and a big eye center in Sierra Leone. Well, that's only been done once by Lowell Guess about 45 years ago. So, what does that look like? How do you do that? It's all new. And so the creativity that I think enables me to approach and be willing to sit in those challenges and try to work through them is running all the time. And so when I'm at home and I haven't done something creative for a while, I'm like, oh, let's try to see if we can build this, or let's try to make one of these. So I've started making drums. I've made about 6 snare drums recently. I had to figure out how to do that in the garage. It took me quite a while. But I'm just fascinated with how things work and really interested in and how to make things happen in the world. And so I think it's all kind of the same thing. But if you spend all your time just on surgery, it's a bit overwhelming and draining. I love the wood shop because you can make a mistake and crumple it up and throw it away. You certainly can't do that with somebody's eye. And so being able to be creative in a low stress environment where I don't have to worry about what somebody's paying me is a real relaxation. I
Yeah.
do think the exercise side of it too, the travel is hard. There's no doubt that sitting on airplanes, flying back and forth, Indonesia is a long way away. It's a lot of time on an airplane, and the jet lag and all of that. I think you really do have to work on taking care of your health. Dr. Sklar will laugh at me for that because the last night we were in Sierra Leone, I had a margarita with ice in it and then spent the plane flight home like with a fever curled up in the back of the plane, trying not to die from whatever I picked up. So, it's actually pretty hard work. Sierra Leone isn't too bad. The hotels are pretty nice. South Sudan, you know, you're working in the heat, you're hungry, you're thirsty, it's 115 degrees, you're bent over, you can't raise or lower the table, and you got to do surgery for 12 hours anyway. And having some physical health is really pretty important for that. So I would say that that's a sort of it's a factor I hadn't thought of too much, but have realized as I get older how much of a difference being in shape makes for some of that travel. I think that's something that helped Jeff Tabin maintain the longevity he's had as well.
Yeah, very well said. And I think that's something that I didn't think about as much, although I always want to ask global ophthalmologists how they keep up their immune system because you would think that, going back and forth, traveling during a COVID era, and then working nonstop can be very challenging.
Yeah, I mean, I'll comment on that. I got COVID in Nepal in February of 2020, right at the beginning. I was pretty sick for a while. That was the first COVID, alpha or something like that. It was pretty rough. I've been sick on other trips. I don't get sick too much, but I've done some of these trips with a torn meniscus and a variety of things. And as you mentioned earlier, some of the places are rather dangerous. There's a real sacrifice to global medicine. I think I would definitely say if you want to make a difference, you're going to have to give up something. Um, I don't get paid when I'm overseas, so 2 months out of the year, basically, I'm not earning a salary. So that's, it's a substantial amount of money to give up. I think it's totally worth it. I wouldn't change it, obviously, but if you're hoping to have it all on this side and also have global ophthalmology, I think you're going to find that that's pretty much impossible. You're going to have to give up some money, some career advancement. Uh, you're going to have to risk something. And I think there's something beautiful in that I think all real love for your fellow man or for one individual is part sacrifice, and that's a real part of the global ophthalmology process. But it's something that I feel honored to be able to share with patients, like the little boy in South Sudan who had never really seen. He went blind at like 4 months old. The it, the suffering to help him, the fact that I have to go there and sort of suffer along the way in order for him to see, in some way makes it even more special to me.
On that note, Dr. Williams, thank you so much for giving your time and your expertise in this field. I feel like we've been wanting to have you on for such a long time, and finally we've made it happen. So thank you so much. I I think I learned so much about what you have gone through and why exactly you have opened the Go Fellowship in at Duke and how you are going to structure it. I think it's going to be a fantastic fellowship, and anybody who goes after it is going to be immensely lucky to get that mentorship. So we're going to bid adieu to all our listeners. Um, but Dr. Williams, thank you so much again for being here.
Yeah, and thank you for what you're doing, Rizal. It's been wonderful to sort of watch you as you've grown and the work you're doing, both with me and with the Moran people and the podcast. And I just wish you all the best. Like it's really great to see what you're doing. I'm super excited to see where you go.
Thank you.